Good morning. I'm Dr. Sean Coomer, Chief Medical Officer for the Kansas City Division of the University of Kansas Health System. This is Open Mics with Dr. Coomer. With cancer surgery, less is more. Surgeons want to leave as much as they can intact while only removing what is necessary. But that's not easy with cancers of the esophagus, stomach, or even colon. Traditionally, surgery in those areas involves partially or completely removing that organ. But today, we're exploring a less drastic option, an endoscopic option, with a camera and surgical tools reaching down the throat and into the GI tract. This lets doctors remove just the tumor, but only if the right doctor is at the controls. Today, we're meeting one such expert to learn how these advanced endoscopic procedures compare to traditional surgery. We'll also meet a cancer survivor who chose this route versus having his entire stomach removed. And we'll see some pretty fascinating footage captured inside someone's throat. Joining me today is Dr. Tuba Esfandari, a gastroenterologist here at the health system. How are you?
I'm doing fine, thank you.
Thanks for being with us. Also joining us via webcam is Gary Peterson, who's been treated for a couple of different cancers, including a stomach cancer that led him to Dr. Esfandari. Gary, good morning. Gary, right off the bat, I want to acknowledge your speaking voice. You had some vocal cord cancer in the larynx years ago, and the treatment changed your voice, correct?
Correct.
So that was cancer number 1 for you, but we're about to discuss your treatment for cancer number 2 in the stomach. But you're also dealing with cancer number 3 as well when you were diagnosed with lung cancer. What is your status with regards to that?
We have done the chemo, we've done the radiation. They did the last PET scan, showed some activity, but they believe it's from radiation and not the cancer. It did not appear to be where the tumor was. So I have another CAT scan in December.
Okay, well, we wish you luck with that one. We'll be praying for you. So let's focus on cancer number 2, this stomach tumor that we've been talking about. These aren't easy to detect early. How did you end up getting diagnosed? Were you feeling any GI symptoms?
No, I had a fundoplication, and while they did the fundoplication, they took a biopsy, and that biopsy came back positive.
Okay, so positive for cancer, that's when you found out, correct?
Right.
So what kind of
But they weren't sure exactly.
Okay. What kind of surgery options were you given? And why did you go to Dr. Esfandari?
Well, originally, they couldn't, once they got the biopsy, they still mapped out the stomach, but they couldn't find the cancer. So they went in and did a mapping, still couldn't find it. And then Dr. Esfandari went in and did something that showed where the cancer was. And that's how I ended up with her, was because she was able to find cancer that nobody else under normal circumstances could find.
So we actually have a photo of the tumor taken out of your stomach. It's more than 7 centimeters in diameter, and of course, nicer to just have that tumor gone instead of your whole stomach. Dr. Esfandari, you removed that tumor with a procedure called ESD, endoscopic submucosal dissection. But let's start by establishing the more traditional surgical approaches. You brought some slides today. Can you explain the esophagectomy?
Esophagectomy and lymph node dissection has been the primary mode of treatment for esophagus cancer. Still it's primary mode for most of the esophagus cancer. And in that procedure, you're a surgeon, you can explain it better than I do, but my understanding is that they remove the esophagus.
Mm-hmm. And that's what we see here in this middle
In the
panel,
middle
right?
part, yeah. They remove the esophagus in the middle part shown. That part of esophagus with tumor on it is removed. Now, on the right-hand side, the stomach is pulled up to the chest, and the surgeon, to make it to fit into the chest, this stomach that looks like a bag, look, you can see it in the middle part, that stomach looks like a bag. It's to bring it to the chest, it is narrowed down to fit the chest and connected to the upper part of the esophagus, just below the throat. And this is not an easy procedure. My understanding is that, in the surgical literature, the 30-day mortality could be as high as 4 to 10%. In centers of excellence with high volume, that mortality in 30 days drops to 1%, but there is significant morbidity. Therefore, that meaning that around the surgery and after the surgery, there could be possibility of a lot of adverse events, such as sepsis, leakage, respiratory failure. And this is just after the surgery. But once the surgery is done and patient goes back to their normal life, years after, the literature in the surgical realm did a study, and they looked at these patients who had 15 years after esophagectomy, removing of the esophagus. And the majority of them, about half of them, had complained of poor quality of life. And that came down to major 2 complaints. One was difficulty swallowing, but as you can see on the right-hand side, the stomach is connected to the esophagus, the upper part of esophagus. Therefore, that area is not protected with anti-reflux mechanisms that normal esophagus has it. Therefore, that reflux can cause a stricture and narrowing in that anastomosis, the 2 parts that were put together. Therefore, they either complaining of dysphagia, or now this stomach that is narrowed cannot have capacity to accommodate for the food. And beside with that, not having the normal route of a stomach, the stomach is angulated at the bottom below the diaphragm. Therefore, all of them have gastroparesis, meaning that the stomach doesn't empty well, and there is no anti-reflux. They have regurgitation and regurgitation of acid and the stomach contents that come up to the chest. And some of them complain of sitting in chair at night in order to be asleep and prevent the reflux. Therefore, even though it's successful, but the quality of life after the surgery is not perfect.
Right. So, I know we were looking at the Ivor Lewis esophagectomy. There are others, but I always tell people when you're sewing a circle, scars always contract. So when you're sewing a circle like that, the anastomosis narrows down and has to be stretched, like you mentioned before. But we've been talking about the stomach, but it's even harder to say the words gastroduodenostomy or gastrojejunostomy. These are the typical stomach cancer surgeries. Can you explain this?
In the left-hand side, the stomach, basically it's in the middle side, the small image on the top, it shows the cancer if it's located in the distal part of the stomach.
And that's the shaded region.
The shaded region. If it is located in the distal part, it's the easiest type of cancer in the stomach to have surgery for. And the stomach is connected to one loop of a small bowel. And this is Billrot 1 on the left-hand side, and on the right-hand side, it is stomach is connected after removing of the tumor. The remnant of a stomach is connected to a loop of the bowel. It is Billrot 2. These are quality of life after the surgery is much better than esophagectomy that I explained it. But they also have their own possibility of complications. Ulcer, the narrowing, the bacterial overgrowth, the bile reflux, and dumping syndrome. If the stomach cancer is located in the upper part, which is where the esophagus joins, that would be similar to the esophagus cancer, the type of surgery, because they have to remove the lower part of esophagus as well as the stomach. Mr. Peterson cancer was located in the incisura, where the shaded area is. At the top of the shaded area, basically his cancer was located in the middle of the stomach. Therefore, I assume that
right about there.
Exactly,
right? Okay.
yeah. Therefore, I assume that his part of the surgical removal of a stomach would be more than just distal stomach cancer.
Now, of course, we have great oncologic surgeons here. The traditional surgical options are still effective, but you mentioned some of the complication. But what makes someone eligible for an endoscopic option rather than the surgical option?
Don't get me wrong, our surgeons are great, and they're on my fast dial of my cell phone. You never want to be on my fast dial. It's a teamwork. Therefore, our oncologist, Mr. Peterson, saw our oncologist, saw surgeon, sick opinion at Mayo Clinic in Arizona as well. There's certain type of cancer that fit the endoscopic submucosal dissection or ESD, and it has to be early superficial type of cancer. If we can show it, the esophagus, stomach, and bowel wall has different layers. Therefore, if you look at it from the top, it's where the surface is, and food, which is in contact with
this is
food.
inside the stomach,
Yep.
and this is outside the stomach. So this is mucosa.
Therefore,
right?
this is where the superficial layer is and is in contact with the food. And this is the superficial first layer. The wall of GI tract is made of 4 layers. Therefore, the first layer is mucosa. The second layer is submucosa. Submucosa means underneath of the mucosa. The third layer is muscle layer, and then there is serosa or adventitia layer. The cancer should be in the upper part, what we call T1A or T1B, and some of the T1B, not all T1B. And because as the tumor grows and invades, goes deeper and deeper, there is more chance of the lymph node dissection. Therefore, if the tumor is pretty down in the wall of a stomach or esophagus, there is high risk of lymph node removal, and removing just the tumor doesn't do benefit to the patient. That's why not every cancer is suitable. Only superficial type of cancer, like Mr. Peterson's cancer, that was barely even recognizable. It depends on also the type of cancer, if it's a stomach, esophagus, if it is a squamous cell carcinoma or adenocarcinoma, there is certain criteria to be met from the tumor part. And then after resection, to call it curative, it depends on the pathology report and the margins to be clear, and also the other criteria needs to be met.
So early and superficial is
Early
the
and
key for
superficial.
ESD. So if it's shallow enough, you can cut that out with a scope
That
then,
is correct.
as opposed to surgery. So how does that work? Can you kind of bring us through that?
Let's look at this. Okay. The picture shows that, for the reference, I put the stack of 2 nickels. That is the thickness of esophagus. Therefore, all 4 layers, the thickness is about 3 to 4 millimeter. And the 3 stacks of, a stack of 3 nickels is basically the thickness of the stomach. And all 4 layers should fit into that thickness. Therefore, in the left corner, you can see that the tumor is there. And I mark around the tumor with a rim of normal tissue, because we want to make sure that it's complete resection. Once the tumor is marked, the area of resection is marked and mapped for me, then I inject the fluid to the submucosa. That fluid has a bluish hue to it that basically delineates the muscle layer better for me. And that allows to expand the submucosa so that I can put my scope down to the mucosa with a knife. I cut around it and then tunnel in the submucosa. I need to be close to the muscle layer, but keep the muscle layer intact. The tip of the knife is only 1 to 2 millimeter. Therefore, even though this is really magnified, it's really a small area, and the knife cuts a few fibers at a time, because I want to be deep enough to make completely the tumor, but also not to damage the muscle layer, because the muscle layer would be the backbone for the normal tissue to grow later.
So you're literally burrowing between layers right underneath the tumor.
Exactly.
And
We
keeping
call it-
some normal tissue around it, so you have negative margins.
Yes, this is a new term used for this kind of endoscopy technique called third space endoscopy. Therefore, we have surface, we have the surgery which goes from the other side, and then we have third space in the middle.
So you let us bring a camera into one of these procedures, so let's take a look at that footage. What are we seeing here?
That's me, and then the monitor is in front of me. This is the scope I'm handing. Basically, this is the room that you get your colonoscopy for routine checkup. And this shows the tumor. I use different light to delineate the site, and then I have magnification at the tip of my scope. Therefore, I look the area very carefully, and that's the monitor in front of me. This is the area that looks abnormal, and I'm making marks on it. As I said, I mark around the tumor, but also a rim of normal tissue, make sure. And this gives me a map, because once you start cutting, you might lose exactly where the normal or abnormal area was. Therefore, this is another patient that, we were looking at the esophagus cancer was. And I'm injecting the fluid. You can see that it has a bluish hue to it, and it's now swollen because the submucosa now becomes bigger.
You're lifting the tumor up, right?
Lifting the areas to give me more space to work in. And those are the marking that I made. And this is the tip of needle, putting in, injecting the fluid to expand the submucosa, so that there would be enough room for my scope to dive in.
Okay.
And this is the knife, the tip of the knife. This is really magnified. The tip of the knife is 1 or 2 millimeter. And I'm cutting the surface by those markings. You see, I'm outside of those markings because I want to make sure that. And this is the pedal. I'm injecting more fluid as I go in. This is a teamwork, my other team members. This is cutting through the submucosa, and I told you that the bluish allows me to see the details better, because the muscle layer would be whitish, doesn't get the bluish. That way I know that I'm away from the muscle layer.
Okay. So we also have a photo of the final product taken immediately after that operation you just did. Is that the muscle wall and the tumor on the right?
Yes. Therefore, the upper part is the normal esophagus. Therefore, you're looking like this. The esophagus is like a tube. Therefore, I'm looking from top. This upper part is normal area that has the surface on it. This lower part, the lower half, is part that the tumor is resected, and this is the margin of the cut. You can see it around here. And this lower part, this is the muscle layer with a little bit of submucosa attached to it, and you can see that it was the fresh cut, and you can see a little bit
and
blood.
This was basically right on top of there.
Right on top of there.
And that's the normal mucosa, like you'd see inside your mouth.
Exactly.
And this would be not normal. That's under layer, the submucosa and some muscle, like you said.
Yep.
So you also brought photos in from another case. This time the tumor was a complete ring inside the esophagus. Like you said, it's a tube.
This was an interesting case. I want to mention it that, this person had some difficulty swallowing and went to his local doctor, and he noticed that the esophagus doesn't distend as well, but couldn't find any tumor. Therefore, sent the patient, did the biopsy. In random biopsy, one of them came back as cancer, but he couldn't find any cancer. And he sent it to us. One of my colleagues did chromoendoscopy. This is spraying the wall. This is esophagus. Therefore, looking at the esophagus, he has sprayed the Lugol solution, which is iodine solution. And what iodine is uptaken by the normal esophagus lining. Therefore, the normal esophagus lining should get this brownish discoloration, but as you can see, majority of the esophagus didn't get the iodine, and majority of esophagus is yellowish. Therefore, esophagus is not normal to work with, and this abnormal area, finding the tumor was very difficult. Then when I used magnification and different light, you could see these little bump in the wall, and maybe a lot of them throughout. Therefore, finding exactly where the tumor was very difficult. This patient had seen surgeon before, and the surgeon, prior to seeing me, and the surgeon decided that we don't have a primary tumor. I don't know where to cut, because they cut from outside. Therefore, was rejected from a surgeon. Therefore, that's what came to me. And there was also comorbidities, his age, and a lot of other problems. Therefore, I decided to do esophagectomy with ESD and cutting from the top portion that looked normal to me and the lower portion. Therefore, that was about almost the whole length of the esophagus. And I did it a spiral going, because it has to be on block resection. It has to be all together so that the pathologist can determine if there is any complete resection or not. Therefore, I cut it like this, and the whole esophagus, the upper two layers are taken out. And would you please show the other picture? And in this one, this is the day after. You saw immediately after it looked reddish with blood on it. This is 1 day after. All those cauterized area, now it has the coagulum that is whitish. And then a month later, here it's shown that this is the area that is resected. It's beefy red. And then here, after 1 month, it regrow, the normal tissue regrow for about 1 centimeter, and at 6 months, 6 centimeter grew. And at 1 year, almost the whole esophagus recovered. It's like your skin off your knee, and then gradually it grows back. Except this area that was ulcer and a little bit narrowing that I dilated. At 2 years, the whole esophagus area completely healed with a little bit narrowing, and then at 2.5 years. Therefore, all the 15 centimeter that I resected came back with the normal tissue.
Yeah, so got the cancer out superficially without removing the entire esophagus, all layers.
And he had his esophagus to swallow.
So Gary recently came for a checkup with you, and Gary, forgive us, but we're going to show some footage from inside your stomach. Dr. Esfandari, what's this?
This is inside of Gary's stomach, and this is the incisura, basically that fold that you see at the top. And I use different lighting, and this is the area of scarring. As you said, the scarring from that 7 centimeter diameter that I removed, now we had a scar of about 1 nickel because everything gathered together. Therefore, you can see the scarring is here in the incisura area, and all healed. You cannot really barely recognize even the scar tissue, and with different light I could appreciate the scar tissue.
Okay. So this really showed, there's more footage here showing the resection healed pretty well after 1 year.
Yeah.
Is there data that shows how this endoscopic procedure compares head to head with traditional surgical options?
Yes, this ESD procedure was developed in Japan in early 2000. 1999 was the first ESD. And they have more data than we do. And then gradually from Japan went to the other Asian countries, China, Korea, India, and then to Europe. And North America was late in adaptation of this technique. But the data we have, recent study was done and showed that they looked at a systematic review of about 3,700 patients. They looked at their chart and compared esophagectomy versus surgery, and ESD versus the surgery esophagectomy. There was no difference in overall survival, disease-specific survival, or a recurrence-free survival between surgery and ESD on the early esophagus cancer. Early esophagus cancer. This study is about esophagus. ESD was associated with adverse event much less than the surgery. Here is mentioned 19%, but this is any adverse event. If you get sore throat after the procedure, if you get, some discomfort in the chest, these are all adverse event. But major adverse event for ESD is less than 1%.
Okay. Yeah. So again, just to refocus, that was for early cancer, T1,
early cancer,
not for
T1.
Advanced. That really has to go to surgery and chemotherapy, et cetera. So you mentioned some of the complications. What are other complications that can happen with ESD?
Actually, it's pretty, patients tolerate it very well. Mr. Peterson can explain from his own experience, but I quote the literature when I consent my patients. I bring them down to the clinic, explain it in a comfortable environment, exactly what I'm doing. and the code is about 6 to 10%, depending on the location, depending on the type of the tumor. Because as I said, esophagus has thinner wall, stomach has a thicker wall, and the type of cancer also is important. Therefore, I quote about 6 to 10% adverse event. That could be chest pain after the procedure, could be sore throat after the procedure, could be a little bit of blood loss during the procedure. These are all. But major complications, perforation, fistula, or any of those, God forbidden, is less, 1% or even less.
Okay. So Gary, do you remember your experience on the day of the procedure?
Yes, I do.
Did you need to spend a night at the hospital?
No, I did
No?
not.
You left the same day?
Yes, I believe we did. I did.
Okay. And so what,
know
can
it
you
was-
tell us? Okay, you tell us what your recovery was like. What did you feel like that first few hours and then first couple days?
I was a little lethargic when I woke up, but after that, nothing. I was fine.
So just a
There
day
were no
walk in the
side
park, huh?
Yes,
Okay.
not a whole lot different than the colonoscopy I had.
The recovery is fast. The patients are discharged after the procedure, like your colonoscopy. I send the patients home. Sometimes I keep the patients overnight if they have long distance to go, because if they go to the local hospital that are not familiar with the procedure and they have chest pain, and the more I remove, they get, if it's esophagus, they can get chest pain, and go to the local hospital and they do the CT and they see that there is inflammation, and then they get worried about perforation. Therefore, I keep them overnight. Immediately after the procedure, they are asked to drink. Therefore, immediately they drink liquid. They would be on liquid for a few days, and then they can advance it to puree diet for a week. And then after 2 weeks, they are back to the normal. And this is for esophagus. For stomach, they can tolerate food pretty well,
Right.
1 or 2 days after the procedure.
Well, thank you. So we're here to answer your questions. Please send them in using the links on your screen, YouTube, Facebook, or email the Medical News Network. Let's switch gears and check in with Doc Hawk. As of November 1st, hospitals must resume reporting COVID numbers to the federal government, which means you have some numbers to share with us. Is that right, Doc?
Yeah, absolutely. We are now officially reporting back to CMS. I think we always have, but some of the hospitals, it wasn't a requirement anymore. Right now, so for week 44, which was the week starting October 28th, so moving into November 1st, you can see there on that graph on the far right, we have a little bit higher COVID admissions. This is what this graph is showing. 19 COVID admissions compared to the previous couple weeks where we had more of the 10 or 11. So it is up for the past couple, from the past couple weeks. It is up currently. So we are going to keep an eye on that. Still, we are also monitoring other respiratory viruses such as flu and RSV, but no significant change in there. Still very little activity overall in our community and nationally.
So COVID vaccines are available, of course, but there's still some hesitancy out there. So you recently heard someone saying they were skeptical that they needed to get the newest COVID vaccine or even the flu vaccine. What do you have to say about that?
Yeah, I think that's a great question. I think that is a question that a lot of people have had. Do I need to get it? Should I get it? We've heard people say, I have had side effects from it. But I think the overall answer is yes, we should get it. But a lot of people are hesitant. A recent MMWR report, which is out of the CDC, showed that overall there was low uptake of the COVID vaccine, but also the influenza vaccine for this recent year, but also the recent report was from 2023 and 2024. Unfortunately, what it showed was that for hospital workers, for the influenza vaccine, the uptake was about 80%, and for nursing home workers for influenza vaccine, again, last year, was only 45%. For COVID vaccine, though, Sean, much less. It was 15% for hospital workers and 10% for nursing home workers. This is vitally important, though, because we know and understand that the healthcare workers are at a high risk of being exposed to the infection and, of course, getting sick. And when our caregivers get sick, it's hard to find people to replace those caregivers and give care to the people that truly are sick. But also, there was a recent study that was just published that also looked at mistrust or trust in COVID vaccines. This was a multinational study, and what it showed was that for the past 3 years or so, the mistrust in COVID vaccines has hovered around that 35 to 40% mark. Again, multinational study. What it showed that the greatest level of trust seemed to be in men, those with college degrees and had a higher median income. But more importantly, Shauna, we know this has happened with a lot of people, those people that had lost somebody to COVID-19. And in those age groups and in those people who had lost somebody to COVID-19 were more willing to accept getting the COVID vaccine, or at least listen to information about getting the updated COVID vaccines. So as time has gone on now, people have said they are willing to listen to the CDC, but other institutions, and I think that is vitally important. I think we need to continue to foster trust as healthcare givers and educators. We need to continue to listen to the CDC and our state and local health departments, but also institutions like we are that are academic medical centers, hospitals, and people who dedicate their lives to trying to keep people safe. So I think we know that there is that level of distrust there, and that is a constant battle for us every day to continue to put out, most importantly, accurate information and really listen to people and answer people's questions. Why is this all important? Because we know that the vaccines are safe. And we know that they are very effective. So I think if we can continue to do this, we can continue to increase the level of trust and protect people. Because we know that these vaccines overall are much safer, and the side effects that we do get and have seen in people who get influenza vaccine, and most importantly, we've heard about the COVID-19 vaccine side effects, they are much less and much less severe compared to people who actually get the infections themselves. So I think that being said, we will continue to try to give you the most accurate, up-to-date information. It is vitally important that everybody does get their influenza vaccine for this season and their updated COVID vaccine. Why is that important? Because even in children, we know that the COVID vaccine can help protect against that multi-system inflammatory disorder. There was a recent study published on that as well. We know that also importantly, long COVID affects people on a daily basis, affects their quality of life. We know that the vaccine for COVID-19 can help reduce your risk of getting long COVID and long COVID symptoms or persistent symptoms. Also, we know that the COVID vaccine can help protect against infection. Now, that was one of the big things we were talking about before the show. That is not the main function of the vaccine, but we know in that first 3 to 4 weeks after vaccination, you can have a reduced chance of even getting infected with SARS-CoV-2. But more importantly, for several months out, we know that you get protection against severe disease and hospitalization, and that is vitally important. But what about influenza? We know that influenza, although activity continues to be low, we have recently seen that in October, there was what we believe was our first pediatric or child death from influenza. So it is vitally important to get that influenza vaccine to protect against that, because we know even in years when the vaccine isn't a good match for the circulating strains, it can still have a beneficial effect of helping protect against severe disease and hospitalization. Right now, we believe the vaccine match is good to the circulating virus, so it is vitally important to get vaccinated, again, both against COVID-19 and influenza for those reasons that I just stated.
Great. Thanks, Doc Hawk. You know, all us healthcare workers can, as well as everyone, can be vectors for other people in the hospital, outside the hospital, and get high-risk people infected. So that's bad. And you know, it's never good when a medical thing gets politicized. So we want to follow the science always on these types of things.
You know, and I think that's true. You know, speaking about healthcare workers, you know, it is vitally important because you said they are vectors. They can transfer it to other patients. They can transfer it to people in the community, their loved ones in their home. We have a robust infection prevention and control group here. You know, that works daily to help reduce the risk of that happening, to keep our patients and our employees safe. Again, we want to keep our caregivers safe. We know that in Rwanda, in the most recent Marburg epidemic or outbreak, that there were a significant amount of healthcare workers that were sick. And again, when you have sick healthcare workers, who are going to take care of the people that come in that are needing care as well? So I think you're exactly right on that.
All right, thank you. So we know many of you have questions. Let's head to Studio B with Alexis Del Cid.
Jeremy has a question for Gary. Jeremy wants to know, how soon after the procedure did you start feeling better?
I had no real ill effects after the surgery whatsoever. So I would say immediately.
And could you eat and drink just like normal? Were there any limitations?
I think it was 2 days.
Oh, wow.
that I was on liquids only, and then Dr. Savari said, go for it.
Okay. Jill wants to know, why is it so hard for these tumors to be found by others? Is it the tools that you use?
Alexis, would you please repeat your questions? I have a little bit.
No problem. Jill wants to know why it's so hard for other places to find these tumors. Is it your specific tools that are able to find them?
Yes, for detecting the tumor during endoscopy, either it is colonoscopy or upper endoscopy, you need a partnership of two persons. One is your endoscopist, your physician, and also the patient. Follow the direction very carefully. If the stomach is clean, and then I use different lights if there is any area of that is suspicious, and look very carefully. I use magnification to have better understanding of what the abnormal area is. If there is anything in question, if there is any question about the area of abnormality, I do extensive biopsy. Therefore, you really need partnership of a patient and the endoscopist to diagnose these early tumors on time. And for the patient part, I have to mention that follow the colonoscopy recommendation, that how to prep your colon. If the instruction says don't drink or eat before the procedure, is because then we will have better, lining that I can see if it is not covered with the food or bile or, residue, then I will have better chance of detecting.
Jean has a question about early symptoms. Is difficulty swallowing one of the early symptoms?
Difficulty swallowing, and also the people who have high risk, Gary had one cancer, and he had a lot of acid reflux disease that he had surgery for that, and cancer was found during the surgery. Therefore, we have genetic counseling that who are the people at risk, but also for esophagus cancer, the Caucasian men in their middle age, if they have had long-standing acid reflux symptoms, even if they don't have it on a day-to-day, but it has been long-standing, those are at high risk. Smokers or heavy alcohol use, they are at high risk. And for stomach cancer, even though it's not very common in United States, but still, infection with H. pylori, and when you have the symptoms, have a good endoscopic examination to find the areas that are suspicious are very important. And for the colon cancer also, the family history, the genetic testing can identify the people at risk.
Jean has a follow-up question, and this is for Gary. Gary, Jean wants to know which of these procedures or battles, you've been hit with so many different battles with cancer, which was the one that affected your vocal cords?
Vocal cord cancer.
That would do it, vocal cord cancer. And that's in remission?
Yes, 15 years ago.
15 years, way to go. Marie has one more question. Marie wants to know if the surgery affected what you can and cannot eat. Do you have to avoid any kinds of foods?
Absolutely not. I try and stay away from spicy stuff due to the GERD, but other than that, no.
Wonderful.
Well, great. Let's get final thoughts. I want to start with someone that couldn't be here today. We caught up with Gary's wife recently, and she had some nice ththings to say about Dr. Esfandari.
The doctors here are amazing, and I'll just call her Tuba because I feel like she's a friend at this point. But she's been great at explaining everything in layman's terms. When she was explaining the procedure, she had a paper towel and a pencil, and she's doing this poking motion and explaining exactly the layers of the stomach and what would be involved. And she's just made everything more simple. We've been able to approach it with a much more relaxed attitude, understanding fully what was involved every step of the way. She's just been great.
Gary, I'm sure your wife has been a huge source of support through all of this. I know Dr. Esfandari is touched by that. What do you want people to take away from your story?
I would just say, if you can do it, because it is hugely different than what the alternative was. And doctor, thank you very much for everything you did. I appreciate it.
Thank you.
Dr. Esfandari, final thoughts?
Again, I want to bring up this point that not every cancer is suitable for ESD. We are a teamwork. Even sometimes after the tumor is resected by ESD, the tumor could be upgraded or low graded. Therefore, listen to your doctors. We all discuss it behind the door with each other. What is the best approach for your case, specific to you as a patient?
Well, I'd like to thank all of our guests again, and to our audience, please seek your health care with your docs. As Dr. Esfandari just said, there's wide-ranging treatments for all sorts of different cancers, and you may be a candidate for minimally invasive surgery as well as maximally invasive, which can be handled here at the University of Kansas Health System. And to our audience, see you again next week.
Kenny Karczewski refused to believe open heart surgery was his only option. I'm Alexis Del Cid on the next All Things Heart, how a second opinion here at the health system led him to a much less invasive solution.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.